and what his past life looked like versus what he's doing at this point in his life, being at Rutgers University. But this is one of the commitments that we at Cornerstone made, right? So when we did our first two programs, we did some surveys, we came back, and you wanted to hear people from outside. You wanted to hear from experts outside of our realm where we had our co-chairs. So we have found Gary, and Gary's been kind enough to provide this payer landscape. And I know Josh is going to kind of go back and forth with Gary on some of this, not really go back and forth, but kind of it's like a dual radio show, like Good Morning America or something. But please, if you want to ask questions, feel free to ask those questions. Dr. Kamadi laid it out. He is asking for 2 questions from everybody, so it's going to be a lot of questions. So Gary, with that being said, I'm going to hand it over to you.
Great. Thank you, Brian. So as Brian mentioned, I am a professor at Rutgers University. I teach some crazy courses in the pharmaceutical MBA program, as well as the pharmacy school. They range from U.S. healthcare structural and policy to market access and reimbursement for drugs. So that's where my expertise lies, is how the payers manage and pay for drugs. So we're going to talk about RX coverage utilization. I love the fact that you've added financial modules to this program, because one thing about the United States, our healthcare system is a financially motivated healthcare system. You have to know where the money goes and how the money's being managed. So we're going to talk a little bit about how the payer landscape works. So next slide, please. First of all, just as a baseline, when we talk about drug coverage and reimbursement, there's 2 sides to the coin. There's the pharmacy benefit, which is self-administered. That's anything that, you know, people get from a licensed pharmacist, where they put an eye drop in their eye, they inject themselves, they take a pill. All that's all done through the pharmacy network, and it could be retail, it could be specialty, but there is no reimbursement to provider. When you write a prescription, there is no reimbursement to the provider. The patient has to pay the out-of-pocket cost, and this pharmacy benefit, which tends to be managed by the pharmaceutical benefit management companies, has a lot of utilization criteria, which we'll talk about later, such as tier placement, copay, coinsurance, and even, you know, step edits and prior authorizations, reauthorizations. We'll go into those in a couple of seconds. But the way that this works to the health plan is that they get the net price of the drug minus the copay. And the net price is not what the pharmaceutical manufacturer charges. That number's not publicly available. The net is after rebates to the health plan. And if you think about the rebate market in the United States, for most branded drugs, the pharmaceutical manufacturer makes about 50 cents on the dollar. And that other 50 cents, about 80% of it goes to the payer audience. When we think about a pharmacy benefit and you hear Part D, that is synonymous with the pharmacy benefit on the commercial side. The medical benefit, what's synonymous there, is Part B. The good news about Part B is that Part B, under Medicare regulations, is buy and bill, which means the provider has to buy the drug, they have to collect the co-payments, they administer the drug, they bill for the drug, and they get paid. This buy and bill is based on a set J code. J code is a HCPCS2 code, which represents all drugs. So if you ever see a J, that J is always a HCPCS2, is always a drug. Could also get paid for the office visit. And the way it's reimbursed today, except Dr. Kamadi mentioned this, is that with sequestration, that ASP plus 6 could go down. It's ASP plus 6. And for biosimilars, certain biosimilars, it'll be ASP plus 8 starting in October of last month, for the next 5 years, to kind of accelerate the utilization of biosimilars. There's a patient copayment for the office visit, but many Medicare beneficiaries have gap insurance, which picks up the copayment. So next slide, please, Brian. If you think about the sources of healthcare coverage, and this is a tricky slide because red matters in this slide. If you think about the way healthcare is divided in the United States, we really have the public sector and we have the private sector, also known as commercial and the government. What's interesting, though, is on the government side, Medicare, 50% of what was Part B now is administered through Part C, which is the commercial payers that you see in the red. For Medicare Part D, it's all commercial players. For Medicaid, it's mostly managed through The commercial players, except what you're finding on the drug side, the states are taking it back right now. DOD and TRICARE, which is probably not of interest in the VA, similar, but the commercial sector of the business is now managing all of the business. And you could see when we talk about commercial insurance on the private sector, it's dominated by the employer-sponsored benefits, which are group benefits. People are signed up in groups. So if you have people that have benefits, they sign up as a whole group. We're still at about 8.6 uninsured in the United States, but the thing that has grown the most in the United States is Medicaid right now. Anything to add on that, Josh?
No, I don't think so.
Hey, Brian, any questions so far from the audience?
Nothing in the chat feature. Again, if you want to ask a question, just unmute yourself and please feel free to ask a question, or put it on the chat and I can read the question. But please jump in with any questions or comments.
All right, well, Brian, let's look at the characters then. Let's look at the characters that actually administer all of the benefits. Since I said it's administered on the commercial side, even for Medicare Advantage and Medicare Part D, what you'll see is that these are insurance companies considered insurance benefits, which means they're regulated by state insurance laws. So when you think about the competition that these health plans engage in, the state border are all the lives that they're trying to recruit from, which means that they have to be competitive within every state. So then you're going to ask me like, well, what's the difference between national and regional then? National just means that they're licensed in more or many states versus the regional plans, which may be licensed in one or two, sometimes three, but more like onesie twosies. But the national plans have the ability to leverage their rates across multiple states. So for example, if you're in the state of New Jersey, where I'm from, Horizon Blue Cross and Blue Shield has a very hard time competing with the national plans because they want the lives in New Jersey. The way they do it is they can bring their rates down in New Jersey to collect premiums from beneficiaries signing up for lower level rates and then pass those rates on to other markets. The regional plans, since they're confined by the geography, they can only get members from within the state. One thing you can find about the regional side of the business though, like the Blue Cross and Blue Shields of so Excelis, Primera, Blue Cross and Blue Shield of Alabama, Blue Shield of California, Care First, Blue Cross and Blue Shield. I know I probably said Blue Cross quite a few times now. That's because what you'll find is in any geography where there is a blue, whether it be a metropolitan statistical area or even a whole state like Alabama, Blue Cross tends to be the dominant player in that marketplace. So they call a lot of the shots in that marketplace. But as you can see in the last bullet point, they also now are involved in Medicare Advantage, Managed Medicaid, and they're the ones that are running the state insurance exchanges that you hear about all the time with the expansion under the IRA right now, which is the Inflation Reduction Act, which is really just an extension of the Affordable Care Act. Any questions so far on health plans? Because then we're going to go to the character that's kind of hidden behind the scenes, which is the one that manages the pharmacy benefits. This is the PBM. The PBMs are not today, I use that word kindly because they're not regulated today by state insurance laws. In 2018, there was a Senate Finance Committee hearing to uncover the practices of the PBMs. Once that started, and a lot of folks in Washington got an idea of how PBMs operate and make money, some states have actually now engaged in trying to regulate the PBMs a little bit more, but it's not a federal regulation. So PBMs typically are not regulated by the state insurance laws because they're not considered insurance companies. They only establish the pharmacy benefits and policies. They don't assume risk, except for, I have to use that tongue in cheek because they do assume risk for Medicare, except for when it gets to catastrophic coverage, 80% of that now goes to CMS's responsibility. But in 2025, that will shift over to be 60% on the health plan side. So they're going to be a little bit more critical about what drugs that they cover coming into 2025. But they manage all of the pharmacy. If there's a pharmacy benefit, because they started with adjudicating claims at the pharmacy, both retail and specialty, these organizations decide how things work in the pharmaceutical benefit side. But they'll also manage all of the Medicare Part D benefit. and they'll also do managed Medicaid for many of the states as well. As you can see, the top three make up almost 80% of all claims processed in the United States. Now, I use the word claims because it looked like, well, those three organizations are massive when it comes to the pharmacy benefit. Yes, they are. But their clients still have the ability to choose different benefits. And you'll see that in a couple slides, why that makes the job of the community oncologist very, very difficult, because you could have, 10 people come in carrying the same exact pharmacy benefit card, all could have different benefits with different benefit structures. Josh?
Yeah, I think I would add to that, you were talking about state-specific legislation, some of which has already been put in place around PBMs, and other states have things that are in committee right now that are hopefully going to make it to the floor of the state Senate or House soon. I would really encourage everybody on the call to familiarize yourself with what's going on in the state legislature, because as Gary goes through some more of these slides and we learn more and more about how PBMs are structured, you're going to recognize the fact that one of the primary ways that we can sort of battle back against some of the PBM antics that you're going to hear about is through legislation. And the PBMs right now have a significant influence over how we are allowed to operate essentially as pharmacies and as clinics. And if we allow them and keep sort of yielding power to them, they will erode community oncology about as quickly as any other type of organization that exists in the healthcare landscape today.
Exactly. Thank you, Josh. I mean, I created a new name for PBMs because what they are in healthcare is they're the ATM of healthcare. Because if you think about it, they make all of their money every time a prescription moves in the system, they make money. And what I mean, one prescription, they could make 4 or 5 different service fees on one prescription. So their entire job is like an ATM machine. If someone takes money out, there's going to be a fee. And that's exactly how the PBMs work. Sometimes I wish I invented it. I think there's a question came in the chat.
Yeah, there's a question about.
Oh, go ahead, Josh. You ask it. Josh. Go ahead.
Yeah, so there's a question about how we can become more involved and learn about the state legislator issues that are pertinent to us. When it comes to pharmacy related and PBM related state laws that are either in place or bills that have been written, there are a number of websites and resources out there that summarize it for you. I know the Community Oncology Alliance has a lot of that data that is being managed in real time and updated in real time. So you can find out what's pertinent to your state and what sort of bills might be in the works. And then from there, you can contact your state representatives to determine whether or not there's something out there that you can support, or perhaps something that you can help to develop.
Yeah, and there's a state. Go ahead. There's a statewide insurance database that I'll give you, Brian. I'll send you a link to it so you can send it out to folks, and then they can go right to their state and see what laws are being crafted, not just for the PBMs, but anything that's in healthcare.
So I think, Azam, 2 places which I found useful. One is COVA, like Josh mentioned. And the second one is the Association of Community Cancer Centers, ACCC, gives reasonable information. ASCO has been lacking, and in my own opinion, they are more favoring academic institutions rather than really helping the community practitioners. ASH doesn't even know that community oncology exists. Quite honestly, ASH does not care about any of your community practices. So they're really missing in action. We've never seen them. So that's one thing with ASH that I do not like about their organization, is that they do not think community oncology actually exists. And then finally, your state organizations, for instance, in Arizona, we have the Arizona Clinical Oncology Society, which is again a branch of one of these, and definitely I would support them also. So those are the 4 or 5 best places to get information from.
Yeah, this is Annette. I wanted to add. Hi, this is Annette. I wanted to add, yes, your state medical societies and also the AMA as well would have that information.
Correct. Yeah, medical societies are a good place as well. All right, let's talk about what has happened with the mergers between PBMs and health plans. 2018 was a big year. So next slide, please, Brian. What you'll see is in 2018, CVS purchased Aetna, and you'll find that Cigna purchased Express Scripts. Express Scripts was the #1 PBM. CVS was #2. Express Scripts handled Anthem. Anthem started their own PBM, gave it to CVS. So you're starting to see the plan here is that these organizations are very large. United and Optum. Optum used to be called RX Solutions out of California. United used to use Express Scripts. Then they formed their own PBM and spun it off of RX Solutions, named it Optum RX. They've also been picking up a lot of provider care. So United wants to be known as the provider organization, but there's been some challenges of antitrust when they move into someone's neighborhood, because obviously they're going to be in United's network. And then you have the CVS companies, family of companies. They're trying to be the consumer-friendly organizations. They want to deliver healthcare where the people are. Anthem, very strong in local markets because a lot of their plans are called Blue, except that they've changed their name to Allianz now. I guess they want national recognition as well. And then a lot of people get confused by Blue Cross and Blue Shield Association, which really is not a collective of plans. All the Blues are independent unless they're already owned by Anthem. But what you'll find is that you have these insurers, you have the PBM consolidations, but what's really important to start to understand is how they're starting to manage specialty pharmacy. So you'll see that these organizations, Riova, which is now called Optum, and you have CVS Specialty, and you have Accredo. These three organizations are managing 65% of the specialty distribution. And what they're doing with that distribution is because since they're making the decisions on the PBM side as to what drugs they're covered, they're also managing the providers through mandating specialty pharmacies. So they're requiring what pharmacy they want to go to you. And I know Dr. Kamadi mentioned this earlier, is that these organizations, until someone puts a stop to it, are actually mandating their own specialty pharmacies. And when that happens, that's when you see things that Dr. Kamadi was talking about, such as white bagging, which we'll talk a little bit later on in here. What these organizations did, though, I'm telling you, when it comes to figuring out how to make money, these organizations are genius. So let's talk about the GPOs. So in 18...
Gary, can I ask you a quick thing?
Sure. Dr. Kamadi, go ahead.
Yeah, most of these guys are kind of new. Can you explain to them the differences between brown bagging, white bagging, and the three kinds of things that we're dealing with?
Yeah, I have a slide on that later on. But
perfect. Okay.
Yeah, right. I like taking questions when they come. So what happens is, for Medicare, you have to buy and bill. On commercial, they could require a white bag or a brown bag. And what Dr. Kamadi is talking to there is if they demand a white bag, that means that they're going to deliver it directly from a specialty pharmacy, probably theirs, which eliminates all that buy and bill spread and gives them the ability to negotiate with pharma for rebates off of a WAC price, which is much lower. So it lowers their overall exposure. When it's brown bag, it's the same thing. And that would be more common with somebody like CVS, because what they'll do is they'll have you pick it up at the pharmacy, because CVS has specialty pharmacies now, even in stores, where you pick up bag and bring it to the doctor's clinic to be infused. So the community oncologist to be infused, which also takes away the buy and bill process, reducing the overall income to the providers. Is that what you're looking for, Dr. Kamadi?
Thank you. Yep.
And so where I was going just now, though, is that there was a new wrinkle to all of this. And as I said before, they're genius at figuring out how to make money. One thing that happened right before the Trump administration left office was that they put a regulation on the books right in the end of President Trump's term. And that was to say that rebates in Medicare would no longer fall under safe harbor, which would make all rebates illegal in Medicare. Well, they announced that they were going to do this in 2018. So what Express Scripts did, the one that's probably the best at coming up with schemes to do these kind of things, they created a GPO, because the genius of being a GPO, membership fees, which sound just like rebates, those membership fees fall under safe harbor. So GPO falls under safe harbor, rebates didn't. So what they did was they protected their rebate revenue by creating a GPO. So that legislation stood on the books till the Biden administration took over, and then they pushed that legislation out further till 2023, which is this year. And then they pushed it even further out to 2032 now with the IRA. So even though that legislation is probably here and gone forever, 2032 sounds like a really long time. In the meantime, these organizations set up their footing. They exist. MSR is in Ireland, offshore for tax purposes. Ascent is in Switzerland, offshore for tax purposes. Zinc, which is CVS, is in the US, but all these organizations now collect additional rebates just to list the drugs that their customers can choose from. So it doesn't take away from what the PBMs were doing, but it added another layer as to where the PBMs can protect themselves from anything that may get passed that is a result of safe harbor legislation. So can you, I just saw a question. Go ahead, Josh, or can you see it?
Yeah, he's asking, can you explain how rebates work? What does it mean to us and our dispensing pharmacies, to the patients and to the payers?
Okay, let's go to the next slide because I'm going to talk about rebates right there.
So Gary, before you jump into that question, I wanted to just make one comment about that previous slide. I mean, you did a great job explaining, sort of the vertical integration between payers and PBMs, and then the newer wrinkle with the GPOs, which I think is just amazing, and how, as you said, how good they are at sort of hiding money.
They are.
It's incredible. But on a practical level, at the practice setting, as difficult as it is to understand some of these pieces, you have to also work just as hard to keep these practices from influencing people inside of your practice. And what I mean by that is, while you have all of these high level sort of antics going on at the business level, the other thing that you have happening inside your clinic, even if you have a sophisticated medically integrated pharmacy today, every single day in your clinic, these PBM or these specialty pharmacies, CVS Specialty and Accredo and Optum, are sending faxes to your office saying that requesting refills for medications that are being dispensed from your in-office clinic. Now, how are they doing that? Well, there's supposedly a firewall between like say, for example, between Express Scripts and Accredo. Express Scripts is processing the claims that you are adjudicating through your clinic, and that information is somehow magically making it into the hands of the Accredo specialty pharmacy personnel, and then they are what is called script poaching or stealing. They're trying to get your physicians, or you personally perhaps, to bite on one of these refill request faxes, so that then you inadvertently transfer that prescription from your in-office dispensing program to their specialty pharmacy. So their antics don't know any limits. So you have to be on the lookout at all times.
Yeah, if you want to, it's just for fun. If you want to watch a YouTube video called Fill My Pockets, so just like the name, PHIL, My Pockets, there's a video talking about the dark side of the PBM business and all the little tactics that they use. It's kind of entertainment. But you'll see there's a couple things here. What you'll find with these organizations, though, is that when it gets to the rebating, that's when things get a little bit complicated. So let's take a look at the next slide. The old way that rebates worked, and I'm going to tell you the good news and the bad news of this. The way the old business worked is the pharmaceutical manufacturers would negotiate with the PBMs to pay them a rebate. So they would invoice us to pay a rebate for every prescription that was filled for a product under the contract with that PBM. And then those rebates would get passed down to their clients, which could either be an employer or it could be an insurance company. What happened there, though, is that probably about 8 years ago, folks realized that PBMs weren't being that transparent and they weren't passing the rebates down. So now they pass the majority of the rebates down, but they also collect an administrative fee to pass the rebates down. So they'll go to the pharmaceutical manufacturer and say, hey, I'm passing the rebates down to my employers and my insurance companies. So I'm going to need an administrative fee from you, the pharmaceutical manufacturer, so I can cut those rebates up and send them to my clients. They also go to the clients and say, well, if you want your share of rebates, I need an administrative fee from you because I'm going to have to cut those rebates up. So that's actually a duplicate fee that they would get to do the same job twice or once, actually. What has happened and has changed since then, though, is that they stuck the GPOs in the middle to negotiate a membership list. Now they work with the pharmaceutical manufacturer just to get listed. That listing then means that their downstream clients, which is now called a participant, which is actually the PBM. So when you talk about Ascent, which is Express Scripts GPO, their number one customer is Express Scripts, the PBM. That PBM is still selling services down to their own clients, the insurance companies and the employers. What's fascinating, and probably the piece that baffles most people, though, is that they negotiate, as I said before, pharmaceutical manufacturers make about 50 cents on the dollar. 80% of the other 50 cents goes to the payer side of the business. That is not used to reduce the patient's exposure. So when a patient has a 20% cost share, it's on the gross price of the pharmaceutical and not the net price that was negotiated by the PBMs. So I don't know if you wanted me to pause there or not, or Joshua, you wanted to add to that, but a lot of people, based on that Trump rule that I mentioned to you that was signed off in 2020, unless the rebates in Medicare were passed directly to the point of sale to benefit the beneficiary, they no longer fell under safe harbor. But that rule got pushed out to 2032 now. Josh?
No, that's great. I would just add, not related to this piece, but if we were to expand, this flow of dollars even further, the other side of rebates that can affect dispensing programs or medically integrated pharmacies, as well as practices as a whole, are rebates that are related to the contracts that you have, that your GPO negotiates between you and the manufacturer. So that's a whole different sort of topic, but you will hear a lot in your practices about rebates that the actual practice receives based on a drug-specific contract for a branded drug. And those do have a significant influence on the net cost recovery that you have from quarter to quarter. They will influence how you manage your inventory. They will influence end of quarter buy-ins. They can sometimes influence what your preferred formulary looks like, especially for things like biosimilars and perhaps other agents where there's the ability to choose a preferred agent. One that comes to mind is the CDK4/6 inhibitor class is a really good area where that can be done. So that's a different side of the rebate piece, and that's between the GPO and the manufacturer and comes directly to the practice.
Yeah, and the good news about that, Josh, is that when we're talking about the pharmaceutical benefit side, you're talking about the medical benefit side now. The PBMs haven't figured out exactly yet how to manage the medical benefit side. They want to get there. So stay tuned. They're dipping their toe in there, but they can't manage it. The only way they can manage it right now on the commercial side is what we were talking about with Dr. Kamadi, which is to force brown bagging and white bagging and things like that. But that revenue stream that you were talking about too today, that medical benefit side, those that are where the reimbursement comes from the insurance company and not the PBMs because it's going to the doctor's office, that still has there's a lot of opportunity, like you said, Josh, managing that inventory, managing the back end rebates, managing your front end GPO off invoice discounts, all that can be done on the other side. These GPOs are, even though they have the same name, really serve a different function than they do on the medical benefit side, as we talked about before. Really, it's just a matter of getting a listing so that they get additional rebates. Next slide, please. I mentioned before that you could have 10 people carry an Express Scripts card into your offices, and all of them could have different benefits. Why is that? Because a PBM like Express Scripts may be managing somewhere of upwards of 2,000 benefits. And the reason I say that is they'll manage a baker's dozen on the national formulary side. Well, they'll try to sell that to employers and regional health plans. But on the customized formulary side, you'll find that employers customize their benefits, Regional plans customize their benefits, and large plans will customize their benefits also. And when you start adding those all up, because think about a regional plan like Blue Cross and Blue Shield of Massachusetts, trying to garner the lives within that state, because that's what they're trying to compete for. They may have 12 or 13 benefit designs to try to be competitive to make sure that people can afford their benefits through Blue Cross and Blue Shield of Massachusetts. Cigna, who owns Express Scripts, will customize their own benefits in every state they compete in if the regional plans are doing the same thing. So Cigna will tend to customize their formulary in every state. So they're going to have another baker's dozen in every state. When you start adding that up, and the 67% of all employer lives are through self-funded plans, which tend to customize their benefits as well, you're going to find that someone like Express Scripts is managing well over 2,000 benefits. Like, for example, being a Pfizer employee at one time, how many years ago, I don't even know. But when I was a Pfizer employee, all Pfizer drugs, zero out-of-pocket costs for all employees. Now, there's nobody else in the United States that has that unless you're a Pfizer employee. That would be a custom benefit through somebody like Express Scripts. Just to give you an idea how fragmented it gets. Next slide, please. This is an example of some of the downstream clients, custom clients that Express Scripts, Cigna, Prime Therapeutics, which 12 blue companies own Prime Therapeutics, OptumRx, CVS, and Anthem and GenoRx. And what you'll find is that these organizations will even move around year to year. That movement can also wreak havoc, because if you have a plan that you had gotten accustomed to in processing certain prior authorizations or reauthorizations for certain drugs, in any given year, if they move to a different organization, resetting how that's staged now and what the requirements are, you may end up with some rejections that you may not have been expecting, knowing that something changed, but you might not have known because you might have had one plan move from another. A great example of that is that Blue Cross and Blue Shield of Massachusetts, which last year was Express Scripts, this year is now under CVS Health. So there's movement from year to year, depending on the rates that they get from PBMs. Now, you say the rates that they get from PBMs. So what does that mean, Gary? Well, I'm going to tell you. What happens is PBMs negotiate the pharmacy benefit with their clients. What their clients are aware of are rebates. The rebates can buy down the premiums, but that's not necessarily what their clients are so much interested in. What they're interested in is the rebates, which they can sweep down to their P&L at the end of the year. Those rebates are done through guarantees. So what a PBM will do is they're going to come up with a rebate guarantee for drugs based on certain dollar thresholds, specialty drugs, obviously a little bit higher. And regardless of whether they got a contract or not, they have to pay a rebate on every single prescription filled for that particular client. It's an easier job for the client because they don't have to worry about, what drug was used where and when and what. So instead, basically, if it was a specialty drug, it fell into this threshold of $2,500 for every specialty drug. That rebate then goes down to the client, multiplying it by how many drugs were filled in the specialty category. Make sense? But it's a crazy system, but it's almost like gambling on the PBM side because they set these rebate guarantees. The rebate guarantees are very competitive. Their clients want more every year, and they're willing to switch if those rebate guarantees are higher or lower versus another one. And ultimately could be a switch plan in the middle of this. But all it does is cost rebates to go up year after year after year after year, because the rebates don't go down. They only go up year after year. Next slide, please. Now we're going to get into kind of the management of this. This is a very simple slide, but it needs to be made clear to patients, to oncologists, to anybody that's doing this, is that anybody that has insurance feels that they have access to whatever their physician would want them to have. Unfortunately, the way our healthcare system works and the way access is with payer policies, coverage restrictions, benefit structures, tiers, cost share, and even management of the providers like Josh and I were talking about, sometimes access, just because you have access, because you have insurance doesn't mean that you have access to everything, or even if you do, is it affordable? Because coverage comes at a cost. So the reimbursement all comes down to is if everybody paid, just like if you went to the grocery store and bought eggs, you put the money on the counter, everything's done. In our industry, since nobody pays for the drugs except for the payers, there's an expectation that reimbursement takes place. The way that reimbursement works is different on the medical benefit side, and it's also different on the pharmacy benefit side. But without that reimbursement, providers and patients will not get the needed drugs that they need. Next slide, please. So what a payer does, and this will probably be the only I am on the pharmaceutical side and the consulting side, I work really hard to get affordable access for drugs. When I try to explain this to my family members, like, what do you do again? I said, well, basically, if you get a drug and you paid too much for it, I didn't do my job. They're like, well, you're not doing your job very well. I'm like, thank you very much for that. But that's because the payers are trying to manage a few things which make our job really, really hard. First of all, it's premiums. I told you they compete with those premiums at the state level. That's the thing that people see the most. That's the most transparent. Everybody knows what their premiums are, but they don't know what's hidden behind the premium. What are the deductibles? What are the co-payments? What are the co-insurance for any of the services that they use? So they mix and match these things to determine how to get the lowest premiums and then tuck those rest of the costs away. So for example, if you have a low premium and then you go to use healthcare services and you find out that your deductible is $2,000, frankly, you have to spend $2,000 before you get any coverage at all. Or if you get a drug and even if it's covered and it's a 20% cost share for a $10,000 specialty medication, well, we're just hoping that the pharmaceutical manufacturers provided coupons, but you can't use coupons in Medicare. So they mix and match these so that those folks that use more services, like oncology patients, tend to see all of this, but it's not always that clear to them what their premiums, deductibles, co-payments, and co-insurance mixed and match for all the services that they used. But since they're trying to satisfy the majority, almost sounds like politicians, doesn't it? Since they're trying to satisfy the majority, what they do is they try to keep the premiums competitive, because if you don't compete on premiums, you won't have any members, period. It's all about the competition. Next slide, please. So a couple of things that they do is that they try to manage the physicians. It's a sad but true story, but I wrote an article. I write for American Health and Drug Benefits, and I wrote an article. Shouldn't we put the decision back in the hands of the patients and the physicians? Because we find that when there's a shared decision, that patients are more likely to take their medications. Nothing worse than being surprised when you leave the physician's office and end up with something else delivered to your house or picked up at a pharmacy. But clinical guidelines and step therapy are suggestions for physicians to use drugs in a certain order. They also will tell physicians how well they're doing writing according to the formulary. They can tie financial incentives and disincentives to it. If they don't like what you're doing, they could even send in a counter detailer, a physician counselor and educated, to talk to the physicians. They create the medical policies. They could mandate specialty pharmacy. And Josh told you that they, not even when they mandate specialty pharmacy, they have other tricks where they try to garner your prescriptions. Josh calls them steal them. But they do all of these different tactics to kind to manage the physician and their practices. And then in oncology, as you know, we use a lot of therapeutic pathways. There's provider-driven pathways, but now there's also payer-driven pathways, and the payer-driven pathways are tied to incentives. If a prescription goes to the pharmacy where interventions take place, sometimes the patient can't afford the cost share. Many times the pharmaceutical manufacturer will have coupons to make it more affordable. Those coupons cannot be used in any government business, Medicare or Medicaid, but on the commercial side, they can be used. But because they always counted against the patient's deductible, if the patient has a deductible, and we've had a rise of pharmacy deductibles since 2015 because of the out-of-pocket maximum that was created by the Affordable Care Act. And because of that, we find that a lot of pharmacy deductibles exist. As that deductible is erased by the pharmaceutical manufacturer, another trick that the PBMs do is that they have the pharmacies report that and they reset the patient's deductible. That's accumulating their deductible and resetting it month after month after month. They also do prior authorizations, which you're oncologists. You are certainly familiar with prior authorizations. One thing about prior authorizations that makes things confusing is the forms are different for every payer, and the utilization criteria can be different for every payer. So what you thought may have worked for Aetna for this rare and orphan disease, next time you get a patient 10 days later for a Cigna patient, and you'd use the exact same criteria and it gets rejected, it's like, how could, wait a minute, I did the exact same thing. That criteria and the firms can vary from payer to payer. What they're also adding now is, because of specialty medications, they've added in reauthorizations. So at 3 months or at 6 months, they want to check back in with you to do paperwork all over again to make sure that that patient's doing well on the drugs. If it's a step edit, there has to be a failure or they won't cover it. Substitutions, you will find, even as we get into more biosimilars now that are on the pharmacy side, that we might see more and more therapeutic substitution, which you might write one thing, but it gets substituted with something else. NDC code blocks and exclusions, all drugs, CVS, you probably have found this already or not, but CVS, the largest PBM, has a new to market block. And what that means is, for the first 6 months that any drug comes to the marketplace, they will not reimburse it. They won't even look at it. They won't even talk to the pharmaceutical manufacturer until there's 6 months of activity on that. And then they'll take a look at maybe covering it and talk about what utilization criteria. So I always encourage physicians like you to do medical exceptions, because that gives CVS and friends, so CVS and Express Scripts and then the other PBMs, it gives them some information on how you want to use drugs, and then maybe they'll set up appropriate prior authorizations. We would expect the prior authorization to mirror what the FDA approval is, but PBMs and health plans do not have to mirror what the FDA says our label is. They can go into our clinical trials and pull exclusion and inclusion criteria and rate stricter criteria, which is why I said it can vary from plan to plan. Any questions on that? Because that's an area where they're trying to manage the way the drugs are used, and frankly is taking the power away from you as oncologists. Josh, anything to add on your end?
No, just that, you know, all the stuff that you're talking about, we see on a daily basis. Copay accumulators, I mean, it really hurts patients. We are seeing step edits in the prostate cancer space all the time. NDC blocks we're seeing all the time with biosimilars and other drugs on the oral side as well. So it's definitely, this is not just an academic presentation. This is real life stuff that happens on a day-to-day basis that affects patient care.
You know, I work in prostate cancer too, and Josh, you've probably realized this. So just to make a point even further there, where prostate cancer has now become very, very competitive, and you have multiple products that are similar in therapeutic value, these organizations may consider them exactly the same, and they'll exclude one or two, which means you have to step through a product that you might not really want the patient to use to get the other one. And the only reason that they set that up, Josh, is because they got a better rebate on the one.
Oh, absolutely.
I mean,
Yeah,
not people
anytime.
understand is it's not always a clinical decision. It's financial for these organizations.
Oh, absolutely. We see every single day where on both the oral and IV side, the preferred agent will be a branded product, even in the presence of a generic equivalent. That happens all the time. And it's true right now in the pegfilgrastim market. And it's 100% because of rebates.
Yep. And even to take it a little bit further is the rebate guarantees. Their clients are expecting a greater rebate every year. So the more drugs they use, the higher they want the rebate be, the higher the guarantee goes. And like I said, it does not go backwards.
Right.
It's amazing, Josh, isn't it? I'm baffled by it. Sometimes when I get done presenting to people, I'm like, I just want you to know, I did not make this stuff up.
So if I could, we got a quick couple questions, if I could, from Dr. Zazor. How, capitalized how, is that legal? And aren't rebates a violation to anti-kickback statute?
No, they're not. That's what the Trump administration tried to put in, and they only could pass it for Medicare because they passed it under CMS, which was regulation versus legislation, which would affect everyone. But it still falls under safe harbor. So anti-kickback doesn't even apply because they are protected under safe harbor legislation.
Yeah.
It's crazy. I know. And I love how is that legal?
Agreed.
Sometimes it just makes you want to cry. All right. Next slide, please. So this is the distribution channel, and the drug manufacturer is the one that's going to try to make it. There's not much to talk about on the left-hand side. So that's the traditional full line wholesalers, and there's three big ones: McKesson, AmerisourceBergen, and Cardinal. And what they do is they provide it to any pharmacy that wants to buy it. So you got a prescription, you go to pharmacy, you get the drug. Where it starts getting very different is when the drug manufacturer, because of oncology or rare and orphan diseases, they'll manage the number of specialty distributors and even the number of specialty pharmacies. Sometimes if the drug is so rare, they may only use one pharmacy because they don't want to have all that inventory out for someone that may or may not come or use that drug. So when it's that special, sometimes it may be exclusive one or two or three pharmacies, but pharma companies, for most drugs that are what we call specialty drugs, are going to go through limited distribution. So they're going to choose who they want to manage their drugs, and that's through accreditation. I know Josh is probably going to talk to you about accreditation too, which becomes really important, but they'll choose ones, they'll pick their partners, they'll RFP it out, they'll decide who they're going to be. In oncology, because of community colleges and in-office dispensing and things like that, pharma has been opening up to that. It wasn't always the case, but they have been opening up to that. But the other piece that we mentioned earlier, and Josh and I were talking about this tongue-in-cheek before, is that when pharma goes to negotiate with the PBMs now to get their drug covered, wink, wink, they'll say, so are you using our specialty pharmacy? Well, we were considering it. Well, you might want to think a little bit more about that, because so you'll find that, pharma is almost pressured to use the specialty pharmacies of the PBMs because they also have control over the coverage. But that's part of how it works. When you think about limited exclusive, it's always going to be mail, most likely. Sometimes there's organizations like CVS that let you pick it up, but when you get into the other side where we talked about, and this is not really tied to the traditional side, but on the medical benefit drug distribution, this is really impacted by the coding and reimbursement. On the commercial side, you might find brown, white, and even clear bagging. Clear bagging is when it actually comes from an in-house pharmacy to use in an infusion center. But this is also can only happen in commercial, and it will affect the buy and bill revenue of office administered drugs. But you cannot do this on the Medicare side today. So I think the payers would like to push for some of this, particularly with some of the extra expenses that they're going to find in Part D starting in 2025. So I think you're going to find payers starting to ask for more and more. I don't know if the government's going to bow or not, but just keep that in mind. Next slide, please. You may be all familiar with this, but once that prescription is written, it typically goes through patient support. That patient support can be done by a pharmaceutical manufacturer. They outsource it. They sometimes do it in-house. They want to try to find out if there's ways to help the patient. Once they get that, they'll send it to the specialty pharmacy to make sure that all the forms are filled out correctly. And then the specialty pharmacy will send that PA over to the payer for approval. What a specialty pharmacy will do is once they get that approval, they will do that, make sure they do the benefit verification before they send the drug to the patient, because no specialty pharmacy wants to send a drug, even though way back here in the green, a pharmaceutical manufacturer or their copay or their assistance organization, hub services, may already know that that drug is going to be paid for by whoever has that member. But the specialty pharmacy does not want to distribute it until they re-verify it. So there's duplication in the process here, just because multiple people are checking to see if the patient has the ability to pay for the drug. And if everything works and the specialty pharmacy gets a hold of the patient, then they will send the drug. This may be frustrating for oncologists because sometimes there is a delay. They'll be saying like, wait a minute, I wrote this prescription like 4 days ago. Why doesn't the patient have it yet? Well, my friends in specialty pharmacy, Josh can tell you, getting people on the phone is not the easiest thing that you have to do. So when you're calling beneficiaries up to take possession of that drug and pay their copayment to make sure that they get it, sometimes that's a real issue and one of the complicating factors of getting it when things are still done by phone. Josh, any comment on that?
No, only that that's one of the benefits of having a sophisticated medically integrated pharmacy is that you can take away, you know, a good chunk of those phone calls, which dramatically increases your time to fill.
Exactly. That's why we have you, Josh. Next slide, please. And these are just some services that you'll see on the specialty side. And pharmaceutical companies tend to use this slide as a thinking of like, what do we do versus what does our specialty pharmacy do? And it goes anywhere from benefits investigation, making sure there's no barriers of access getting the drug, whether they have comprehensive benefits, is there any patient assistance, any kind of HCP or office staff support that might be available to them. Then it goes to prior authorization. There's organizations that do electronic prior authorizations like CoverMyMed, PARX, and Prior Authorization Plus, and there's payer portals that do all this stuff. Then the financial assistance, any way that can make the drug more affordable for the patient, to therapy onboarding support. Many of these drugs, even when they're self-administered, require some additional coaching, or even if it's just an oral medication, because of the complexities of the side effects in helping patients navigate through side effects. A lot of that onboarding takes place there, and then making sure that the patients are adherent to their medication. And Josh can tell you, that's one of the greatest advantages of an integrated group, is because that adherence piece, it's good for everybody. It's good for the payer, it's good for the patient, it's good for the specialty pharmacy because they're moving inventory, it's good for the pharmaceutical manufacturer. Patients that take their drugs get the benefits. Josh?
Couldn't agree more.
That's the way I look at it too. So at this point, I'd like to turn it over to my co-host partner there, Josh, to talk about some pharmacy services at this point and how a medically integrated pharmacy works.
Right. Thanks, Gary. I appreciate it. We can go on to the next slide. So Brian asked me to talk about sort of some of the logistics and operations of the medically integrated pharmacy. So that's what I want to do over just the next few slides. Now, for anybody who's on the last or the first call, I believe, you know, we talked about what the definition is of a medically integrated pharmacy, and I'll let you read that. So I won't read it now, but what I'm going to talk about is what's not on there. It's not a dispensing program. There are other organizations that talk about MIDs or medically integrated dispensaries. I really don't like that term. And the reason I don't like the term is because it really minimizes what a sophisticated medically integrated pharmacy can do. It's way beyond dispensing. You can train anybody to hand a drug across a counter to a patient. You can't, you know, you need a more sophisticated team to be able to provide what we actually provide, which I'll get into on the next slide. Or maybe it's a couple slides from now, but you can go and move to the next slide. So what is the value that is brought by the medically integrated pharmacy model? Well, as you can see on the slide, the patient, the orange circle, is at the center. And the reason that we're able to provide superior service compared to any other traditional pharmacy model is because we are one care team that's anchored by physicians working from one care plan within one patient record, all of it being guided by evidence-based clinical pathways. So the team is fully integrated, fully connected with one another, and able to make real-time decisions, to be flexible and nimble, and provide clarity of focus around something that's very complicated disease management that requires very high touch patient care. And all these things lead, of course, to the best patient care, the highest values and the best outcomes. Next slide. So let's talk a little bit about the structure. Now, the structure can vary, you know, relatively significantly from practice to practice, and it'll be driven to some extent by the size of the practice. But even in a 2 or 3 or 4 physician practice model, you can have a very robust medically integrated pharmacy structure. The most important thing about the structure that's not listed on this slide is having the right people. Now, when we started our physician dispensing program about 11 years ago, it was run initially by a medical assistant. And it was fine. 11 years ago, there were what, 10 oral oncolytics available? There are over 100 now. So we were able to, kind of get our sea legs and kind of learn how to build the program. When I say having the right people in place is important, in an ideal scenario, you would hire pharmacy technicians who have either specialty pharmacy or at least retail pharmacy experience. And I don't mean a year or two, I mean years. The medically integrated pharmacy will be dependent on the talent and skill level of your pharmacy technicians. There isn't a pharmacist in the country who wouldn't agree with that. They will be the soul of your dispensing program or your pharmacy. And high skill people are required. That is not an area where you want to save money on human resources. The other piece of having the right people in place, if at all possible, if it's economically feasible at all, is to have a pharmacist running the show so that you can eventually have a fully accredited licensed specialty pharmacy. I promise you that having a pharmacy or a pharmacist rather in charge of a dispensing program or a medically integrated pharmacy will grow the program. It decreases the liability to the medical oncologist, and it affords you the opportunity to offer a much broader array of services to your patients, which will affect patient outcomes. There's a mountain of evidence in the literature for the last 20 years that proves that over and over again in virtually every setting of healthcare. So all that to say, very strongly encourage in the investment in the right people in the medically integrated pharmacy structure. The key value here is that the pharmacy team is embedded into the comprehensive care team, as I alluded to in the previous slide. They have real-time access to the complete electronic health record. This is also critical because it allows them to do just about everything else that needs to be done inside the MIP. They can create a customized pharmacy care plan that's based on the information that's contained in the EHR. They can provide comprehensive ongoing patient education to patients over the phone or in person, depending on how many locations you have. Because of their real-time access to the EHR, they can do proactive dose adjustment monitoring. And what do I mean there? Well, what I mean is that when we're dispensing an oral oncolytic, we are looking at the patient's labs just as you are during the patient visit. We're looking at your progress notes. We're looking at any imaging results that have recently come in to see if there are changes in therapy that need to happen. It helps us to anticipate toxicities, helps us to communicate with you to see if we need dosage adjustments or perhaps a drug holiday or a complete discontinuation of therapy. We can help to reduce waste because of those things as well. Far too often, especially with some of these PBM-owned specialty pharmacies, we see patients getting 30, 60, 90-day supplies of drug just a couple of days before it's being discontinued because we're waiting on a scan to see if it shows progression or not. So then patients come into we also have a drug repository program where we can accept donations. We'll have patients bring in $20,000, $30,000, $40,000 worth of drug that otherwise would have been thrown away, and in most states is required to be thrown away. One of the other things that is obviously incredibly important is to reduce financial toxicity is a financial assistance program. Many practices have financial counselors in the practice that that offer all of the services around the MIP, and that's great. My experience has been it's even better if you can internalize that into your pharmacy structure. So if you have a big enough pharmacy where you have 3 or 4 pharmacy technicians and they can all sort of be responsible for assisting the patients with the financial assistance program, it makes the operation of the pharmacy far more efficient simply because those pharmacy technicians, along with the pharmacist, have control over the entire process, and they're not relying on somebody in a different department with that, exchanging emails and making phone calls and following up with issues to see where they are. Rather, they're in charge of the whole thing, so it can just make everything a little bit faster. So those are just some of the important structural pieces. The benefits, I've alluded to some of them, but it leads to extremely efficient patient navigation, improved access, and the coordination of care is far better. The coordination of care piece is something that I don't think can be understated, because as you know, more and more we are seeing drugs that are being given concomitantly with either radiation or other chemotherapy, it's almost impossible to coordinate care if those oral oncolytics are coming from some outside entity. So we see patients, in those cases, we're seeing patients with delayed starts for their treatments, sometimes having to take breaks in their therapy while they're waiting for their Xeloda, if they're a radiation patient or what have you. I already talked about reduced waste. We have very rapid time to fill. We are, even for drugs that require, all these drugs that require prior authorization, we're able to get drug in hand. For our pharmacy, it's about 1.5 days on average. So from the time that prescription hits our queue, 2 minutes after you've written it, we can get it into the patient's hands in about 1.5 days. Now, the industry standard is somewhere 5-7 days. And although the PBM-owned specialty pharmacies are very proud of that, well, they can't touch 1.5. One other thing I want to say about structure, I meant to mention this when I was talking about financial assistance. One of the important things to think about if you have a medically integrated pharmacy is your pricing structure. In our pharmacy, there's been a lot of talk in the media recently about Mark Cuban's cost plus pharmacy. So what he's done is it's interesting because the numbers are just exactly how we did ours 8 years ago. But what he's done is he takes drugs, generic drugs, and he sells them at acquisition cost plus 15%. Well, if you think about that, a lot of the drugs that exist on the market today, the acquisition cost for a 30-day supply might be 50 cents or $2. So to add 15% to that, patients can get a really good deal. We did that same thing with all of our generic drugs, with our generic inexpensive drugs 8 years ago. So we have dozens and dozens of patients every month that come to us just incredibly happy when they're getting their prescriptions for their drugs like aromatase inhibitors. They might have a $60 copay for a 90-day supply, and they're getting a drug from us for $6.15. And the reason we're able to do that is because we're not trying, we don't need to rely on the margins from these inexpensive generic drugs in order to have a wildly successful pharmacy program with excellent economics. So we use those types of things to increase patient satisfaction, to do what's best for the patient, knowing that if your patient is getting their aromatase inhibitor from us, one day they may also be getting their CDK4/6 inhibitor, which will offset any losses that we might have experienced from taking such a small margin on the generic. Next slide. So I just have three or four slides remaining. I just want to talk about some of the key performance indicators that are important when we are looking at monthly data around our pharmacy numbers. And the first one is with operational KPIs. Far and away, the most important operational KPI is script capture rate. And this needs to be something that's very transparent, right? We need to measure this monthly. And well, let me back up for a second. Script capture is going to be defined as how many in-network scripts did we fill inside the medically integrated pharmacy. And when I say in-network, I mean those drugs that are being mandated to go to an outside specialty pharmacy, we have no control over that. So those should be excluded from your script capture rate. Once you exclude those from your script capture rate, your target should be greater than 90%. And again, we should be looking at this monthly, and we should be looking at it by provider. We need to know in a very transparent way which providers are sending the prescriptions to us and which providers are not, so that we can maximize that script capture in a very rapid fashion. So that is incredibly important. One of the easiest ways to do that is to create a policy inside of your practice that all specialty medications are triaged to your medically integrated pharmacy, meaning that when you're in your electronic health record and you are e-prescribing that prescription to a pharmacy, it should default to your medically integrated pharmacy. From there, if it has to go to somewhere else because of a limited distribution network or because of PBM mandates, the pharmacy team can do that on your behalf. Not only does that ensure that our script capture rates are going to be as high as possible, it decreases the amount of work for the provider. So it's a win-win from your perspective. Also, on a monthly basis, it's important that we identify where every single outgoing script goes. Even if we don't have any control over it, and if it's all just the PBM-owned specialty pharmacies that are receiving our outgoing scripts, we need to know what percentages of them are going there and whether or not they're being mandated to go there. We'll use that information later when we're doing value-based care contracting with these payers and say, we'll be able to say to them, look, we're losing 20% of our business to your PBM-owned specialty pharmacy, and you're holding us responsible for the cost. How can you not allow us to provide longitudinal comprehensive care to our patients, but you're holding us accountable to a value-based care contract? So it's information that we need to know, even if we can't influence it today. Next slide. Let me pause there for just a second and see if there are any questions, because I'm moving kind of quick to try to make up some time so that Brian doesn't have to eat his hat on his 2-hour comment at the top of the session here.
Thank you, Josh. I appreciate that. But this is great stuff, folks. So let's, if there's any questions, please take the time to ask.
All right, so moving on to quality KPIs. One of the biggest ones, it can be a challenge to measure, but is primary medication non-adherence. So for those who may not know, PMN is simply the percent of patients who get prescribed a medication that they never get the first fill on. Depending on what data you look at, it can be 20, 30, 40% of prescriptions that are written are never filled. That varies a little bit in the specialty pharmacy market, but it can certainly be a problem, especially because of financial toxicity. So that is an important metric, quality metric to be aware of, and it's information that can be used to help inform manufacturers as well as to negotiate with payers. The second one is adherence, and there are lots of different ways to measure adherence. The one that is the industry standard is medication possession ratio. It's also the one that is least valuable to the specialty, or at least to the oncology space, but it is the one that most of the accreditation people want to see because it's just been around a long time. But proportion of days covered, and if anybody's interested, offline, we can talk a little bit more about how these things are calculated, but proportion of days covered is a little bit better than medication possession ratio, but persistence is really the best one in the oncology space. And persistence is very simple. It's how long was the patient on therapy from day one until the therapy was discontinued. Another important quality metric is time to fill. That's something that is very valuable to payers that you can use. It's also easy to measure. And then dispensing and distribution accuracy. This is very important for any accrediting body that you're involved in, like ACHC or URAC, which are two very common specialty pharmacy accreditation organizations. You are really required, not only from a quality perspective, but also from a liability perspective, to have very thorough documentation of any of your dispensing and distribution accuracy, as well as conducting things like root cause analyses when an error does occur. I tell my pharmacy team almost every time that we meet that we have to operate like an airline. And what I mean by that is that the goal is error-free. I mean, to err is human, of course, but we have to be diligent in creating the standards of procedure, the policies and procedures, and the workflows that will help to mitigate as many errors as possible and build in those second checks and safety nets that will catch errors when they occur before they ever hit the patient. There's a lot of time spent in that regard when it comes to setting up the operation for your medically integrated pharmacy. Next slide. And the last category of KPIs are the economic KPIs. These are all very, very easy to measure, but you can get very deep into them, and someone within the practice should get deep within them so that they can understand trends as they're occurring. Total script volume is self-explanatory. Obviously, how many prescriptions are we filling each month? Those should be separated out by specialty versus non-specialty drugs. And also brand versus generic medications. This is important not only for contracts, but also for accreditation purposes. And then the last three are all regarding sort of P&L, and it's monthly gross revenue. And that should be done again in total and by provider, keeping in mind how the profits are distributed within your practice. Because if everybody's getting sort of a percentage of the profit distribution from a medically integrated pharmacy, then the monthly gross revenue by provider becomes very important, because you will be able to see who are your underperformers and who are your overperformers. And then if you're collecting the information that I described previously about script capture, you can determine what the causes of that are. Perhaps it's just something as simple as patient mix. or new patient volume for that particular month per provider, or it might be something related to script capture because the provider is unknowingly sending prescriptions elsewhere. Monthly gross profit or profit percentage and monthly gross profit and also monthly gross margin. And all of those, again, should be in total and by provider. Now, I would also say, our central business office calculates all of this information on a cash basis, using cash basis accounting, right? So how much money do we have at the end of the month, regardless of how much we have coming in? I analyze all this data using accrual-based accounting because I know how much money is coming, and I don't want the timing of those inflows and outflows to influence what the total margins look like. I want the physician to have a better idea of what the total picture looks like. And then lastly, I just have a note there that's kind of hard to read because of the Cornerstone logo, but all of these metrics are assuming that we have a system that's set up where we run a test claim for every single prescription that comes through. And what a test claim is nothing more than someone on the pharmacy team adjudicating a claim for a new prescription as it comes in, and then has the knowledge to evaluate each one of those claims to see if the net cost recovery is sufficient enough to justify distributing it through your medically integrated pharmacy. You don't have to make money on every agent, but you obviously have to be able to provide a basket of services to patients that will be in the black at the end of the day. So we do that sort of analysis for every single prescription that goes through our system to ensure that at the end of the month, our economics are going to be favorable. Next slide. So just to summarize some of the critical success factors for the medically integrated pharmacy is, again, I'm going to flip the order here. The number one thing is having a strong pharmacy team. That will, again, be the lifeblood of the success or failure of the medically integrated pharmacy. Maximizing prescription capture, and don't make it difficult. Just send everything to the MIP and let them do the work for you to triage those medications to other pharmacies if the insurance or perhaps the patient really likes the services they receive from some other perhaps private specialty pharmacy. That's fine too, but just tell your patients that I'm going to send it to this pharmacy team and they will determine what's best for you from a financial perspective and from a logistics perspective. If there are any services that are offered through the pharmacy or that are required for the dispensation of a drug that can be centralized to your pharmacy team, do it. It will make the process more efficient. It'll make the turnaround time faster. And then having a consistent and thorough monitoring and understanding of your KPIs that are analyzed by all the appropriate people within the practice to identify trends and opportunities on a very regular basis will help to ensure constant growth quarter over quarter. And looks like we have a question. Do the faxes for refills go to your pharmacy or to the prescribing physician? So, and what policies have we put in place to prevent script poaching? That's a great question. So the faxes, unfortunately, go to the prescribing physician. Our pharmacy is located in one of our 5 clinics. And then we, of course, distribute medications to patients from all 5 locations. So those faxes will come in. And what we saw in the early days of our pharmacy is that we would have a medical assistant or an LPN or somebody sitting next to a fax machine. They would receive one of those faxes from, say, CVS Caremark, and then they would go to their physician and say, hey, Dr. Smith, CVS Caremark says that Jane Doe needs a refill on her Ibrance. So they would simply sign the form and fax it back to CVS Caremark, and there you have it. The script has been stolen by Caremark, despite the fact that we had been filling it for 6, 8, 12 months. So of course, we created a policy that simply says that they don't respond to any of those faxes, but rather send them to the pharmacy. But better than the policy, we provided lots and lots of education to all of our nurses, our LPNs, and our MAs, and our physicians to let them know what that policy was and why we were asking them to take the extra step of sending it to us. And once we told them the why about that, we started getting a lot of compliance with that. Now, we still see some things slip through the cracks, but it's very, very minimal. And we're able to, because of our script capture monitoring at the end of each month, if we miss one, we see it that month and we can get it back. Other questions? That is the end of my slides. I thank you all very much.
Josh, thank you. I first of all, I appreciate you going through, speeding everything up, but it's valuable stuff. So I don't want to take away from that. So if there are any questions for Josh, please, let's take that opportunity. So it looks like we got one here. Josh, if you can see it.
We've had a few instances where insurance dictates that IV treatments should be provided by them directly. This caused delays in treatments. Am I seeing this trend? So I've seen two things happening. I'm not sure which one you're referring to. Gary referred to white bagging earlier on the IV side, where the PBM owned specialty pharmacy sends an infusible drug to us to administer, which takes away the buy and bill. That's one scenario. The other scenario that I've seen is there might be an infusion clinic that's local and that's owned by a payer, and patients are steered to that infusion clinic. I've seen that as well. Now, on the white bagging side, I've certainly have seen an increased trend there. We, however, have created some policies in our state. Well, let me rephrase. We've created some policies using some rules that were created in our state to scare payers away from forcing us into the white bagging situation, and have been fairly successful. We can talk about the details of that offline if you like. You can certainly get my contact information from Brian.
Josh, thank you very much. Thank you. I appreciate it. Great, great talk. So, and again, anybody, since Josh is offering, anyone that wants Josh's contact information, please reach out to me directly, and I'll be happy to share that.